just to just to present the perspective that I'll be coming from. I am an MSF reject, and it's surprising that I've been called. This is the third keynote address I'm giving the Humanitarian ICRC MSF crowd. In the late 80s, I was also an adrenaline junkie, just like y'all, and I applied to the MSF. They said, this was before the Seoul and the Nobel Peace Prize. So I thought MSF had potential even then. So I applied for it, and as a young surgeon, right out of Sion Hospital in Mumbai, and they said, you have to come for an interview to Hong Kong. So I calculated the cost of going to Hong Kong, and that was about 2 years' salary. So obviously that didn't happen. And then they said that a lot of it is going to be in French. So I said, okay, so MSF means must speak French. Things have changed a bit. I can see a lot of brown faces here, and it's wonderful to see that. MSF is obviously an organization I have admired all along. But like Brutus, I'm not supposed to praise it. I'm supposed to also present the other perspective. So I've worked with the government most of the time. I've been a trauma surgeon, as I was introduced. I've also been a conflict and disaster researcher. So my perspective comes from seeing foreign medical teams operate in my country, operate in India. And that's the perspective that I'll be presenting. And obviously, everything that I say about foreign medical teams does not apply to MSF. Some places MSF does really well, and some places maybe not so well, and that's my point, to present that perspective. I'm going to be politically incorrect through my talk. I normally like my talk to be after lunch, because often I've been asked not to have lunch at the end of my talk. But here, I know I'm in an audience full of politically incorrect people, so I have nothing to worry about. At the end, I will be touching upon the whole humanitarian aid in the political context, in the social context, in the government context. And I would like to end by saying that humanitarian aid, the giver and the receiver, both are blessed in the process. And that's something that we need to remember. It's not about the superhero status that we often sort of claim when we are giving humanitarian aid. The 7 sins. The 7 sins are, I'm going to be running them through, but just to give you a quick overview, first is I'm going to be speaking about the first sin, which is leaving a mess behind for the locals, failing to match technology to the local needs, abilities, local rescuers, failing of NGOs to cooperate and help each other, which is a big concern for the government, and always competing with each other. And this whole very, very important thing about accepting help from military organizations, which I know MSF has always been having a hard time trying to find the right position. Failing to have a follow-up plan, mainly in a research plan, allowing politics, media, and other goals to trump service, going where you're not wanted or being poor guests, and lastly, health workers' safety, both physical and psychological. So this is the brief of my talk. I've been allowed only 5 slides by Holly, so I shall take this opportunity to display them. This is how it looks from my end as a recipient of foreign medical teams as they come in. So this is how the standard needs are during normal and disaster times. There is non-trauma emergency, there's trauma, and there's elective work. And there is a sudden onset disaster, conflict, and we can see a big spike in the requirement of trauma. This actually has been done by Johan von Schrieb and gang. They are from MSF Sweden, and they actually did all all the disasters in Iran, Haiti, Indonesia, Pakistan, put all that data together and came up with this graph. And you can see that there is a spike in trauma. All elective surgery stops, and most of the non-trauma emergency also stops for a while, and then this is like cesarean sections and other things, and they'll pick up after a while. That's when we get the humanitarian workers. Over the last 19 years, I've been asking why humanitarian workers come, and they've said a variety of reasons listed here. They say we come because of self-realization, bragging rights, self-actualization, guilt, be meaningful, want to help, give back, do something important, assist those in need, alleviate suffering, pain, diaspora, I want to recharge my batteries, monotony of regular practice, religious convictions, challenge underserved, underprivileged, controlled adventure, adrenaline junkies, I told you, and see new places. So this is my list. And here then you can see the number of hospitals increasing as we go along in the disaster. That's 5 days, 10 days, 15 days, 20 days, and the number of hospital beds because of the foreign field hospitals go on increasing in most places. And that's when the media comes in. And if you superimpose the two graphs, you will find that most of the trauma and most of the work is over by the time most of the foreign field teams come in. And this is the reality. This is the reality that I need to emphasize, that there is a lot of local work which is going on, local rescue which has gone on, and it's never covered in the media. Media is always covering all the foreign teams which have come in, and that really upsets a lot of the local people who have been rendering service. And usually they are there for short term, and the foreign medical teams leave rather rapidly, and I've been collecting the reasons why they leave. And it's been a busy and important practitioner in infectious diseases, health insurance, security, communication, culture, food, heat, inadequate infrastructure. I do only breast surgery, it's too expensive, it's politically unsafe. Personal hardships, equipment, climate is hot, food is hotter, surgical problems beyond my skill sets, corruption, suspicious activity, dangers, accidents, crime, terrorism. Here is where I have the problem, because all this was true for my country before the foreign medical teams came in. How can it be an excuse for you to leave? And essentially, most of the work has been short-term, and that's my second important message, that if you're doing very short-term work, you have only one perspective, and usually the rescue perspective. It's not the rehab perspective. And there's too much of that in the literature, in the media. It's all emphasis on rescue. Finally, the teams leave, and I'm sitting there, the one who stays behind, and we have to clean up. And they said, okay, we're handing over to you, and you're going to be there for the next 2 years, 3 years, cleaning up whatever has happened. And what we found is that though most of the teams this is again types of interventions, again MSF data from post-Haiti. Haiti was very different for MSF because MSF is already working in Haiti before the earthquake. And when the earthquake struck, they were the best teams, obviously, because they knew the local thing, which is exactly my point. If you are flying into a disaster or a conflict zone, you are less equipped than somebody who has been working there. And you can see the type of cases that we saw, and this is classic for all sudden onset disasters around the world, including India, that you really require minor stuff, you don't require specialized surgery. Yet the teams usually come with very specialized people, usually from ivory towers, usually from the universities. And that's not been very helpful, and I will show you the results of what happens. So here are the post-operative results of what happens in post-typical disaster. And on the left side, I don't know if it's big enough, but you can see that there are hardly any head injuries and shoulder and chest injuries because they're all dead. The only people who arrive for the rescue are people with soft tissue, tibia, fibulas, femurs, spines, and pelvis. And what happens to them is they get fixed with the most modern treatment, and ORIF being open reduction internal fixation. And that is the top technique that the Germans taught us, unfortunately completely misplaced in the field. So I have a lot of implant work which would happen in quite a few of the disasters, and then it's changing now. I must say MSF is definitely changing it, and Red Cross guys are also retraining their surgeons to do other kinds of surgeries which are appropriate. And external fixator probably is the correct surgery to be done, but nobody knows how to do it anymore in this day and age. So typically when you are following up the patients and you've had a tibia fibula fracture, a typical rural patient will put cow dung on it, because if you're bleeding to death and if you don't have a doctor, you either put cow dung or mud, and you guys know that from the field. You always have an infected injury. And then if you drive a nail up that marrow and you leave, 1 month later, what would have been a lower leg amputation now becomes a transarticular trans-knee amputation. So actually you've pushed the whole amputation up. Strong message there that we need to retrain ourselves. We think all our skills are going to just kind of translate straight onto the field. It hasn't happened. And these are my results. I saw my own results, and being professor of surgery when I was operating on the field, I was perhaps only as good as a second year resident. So a professor of orthopedics in a medical college or in a university hospital perhaps will be functioning as well as a second year global surgery or a resident in the field. So we'll have to readjust our ideas of how this works, because the results are so poor, and that is possible to know only when you follow it up. So my follow-up studies are 2 years post-disaster, and nobody's there that time. So unless you're researching your own work after 2 years, after 3 years, you don't really know how good you are or how bad you are. And that, I think, is the big need for research. And that's, again, a strong message to have a long-term research rather than very quickly finding solutions to the problems. I agree with you that there's there are diseases of shorter duration, like diarrhea. I mean, you've cured diarrhea, you don't need to wait for 2 years, but there would be these long-term effects of the problem. And health worker safety is, again, one of those issues. We've been very concerned about health worker safety, because whether it is a foreign medical team or a local team, we are never sure of how the safety standards are. So we did this 5-year study. We studied it for a fairly long time in the Northeast, and we were quite upset because some of our friends were picked up in the Northeast and they were doing humanitarian work. And we did a fairly long study on how safe humanitarian workers are. And it was actually quite surprising that the incidence of healthcare workers being abducted or anything bad happening to them was the same as the normal population. So though we keep thinking that we are targeted, and this is true for India, I'm not saying that this is external valid for the rest of the countries in conflict, but what we found is that the number of health workers subjected to any kind of threat was exactly the same as a businessman who's rich in the area, or a school teacher, or a principal, and they shared the risk equally. So that was the important finding that we had, and I'm not saying it's reassuring, I'm just saying that it's our perceived threat probably is the same as the rest of the general population. The other concern has always been about mental health of the humanitarian workers. The mental health status of humanitarian workers. So we studied all the teams which came into Nepal, all the foreign medical teams who came into Nepal, and we subjected them to a 7-part questionnaire to look at secondary traumatic stress. And our findings were interesting. At the end of the Nepal earthquake, after interviewing all the humanitarian workers, we found that the men were 1/3 more likely to suffer from traumatic stress, and women were only 1/4, exactly. It's counterintuitive that women would be less stressed than men. We found that younger people were more stressed than the senior people. We found that the people who have coming in for the first time, and there were lots of them coming in for the first time, were less stressed, and the people who have been there for a very long time, 4 weeks and above, were more stressed. And we found that the clinical humanitarian aid workers were less stressed than the non-clinical workers. So that's how it worked with the humanitarian aid workers. So research in conflict areas, in disasters, is much harder, and I would definitely say that that's the need. In one of the articles that I'd done looking at disaster research, I found that out of 63,000 articles published on conflict and disasters, considering that 90% of the disasters happen in low and middle income countries, the number of publications coming out of low and middle income countries was less than 1%. So most of our understanding of conflict and disasters actually is not coming from LMICs. And if I subdivided that into levels of evidence, you found that most of the conflict and disaster research was mainly op-eds, editorials, what I felt about when I went there. And it was not grade 2, grade 3 evidence. For grade 2, which would be cohort, following up cohorts, and looking at a long-term follow-up, you could find that there was almost no grade 2 and grade 3. We don't expect any RCT, which is grade 1. We don't expect any randomized controlled trials to happen in conflict and disaster situations. But even grade 2 and grade 3 should be the basic aim that we would do. We sub-analyzed the authors of these grade 2 and grade 3, and we found that less than 20% authors were local, and it was mainly foreign teams doing the research, and there was less of local involvement. Yet in the grade 2 and grade 3, which consisted of long-term follow-ups, we found a lot of local authors. And that's a no-brainer, because the local authors are obviously there for a much longer period of time, which is why they're able to follow up the long-term consequences of conflict, protracted conflict, fragile states, etc. So that's the need in research. Within the whole spectrum of research in conflict and disasters, we found that one aspect was missing, and that was looking at mental health and ethics. The whole business of ethics in disasters and conflict is something which has not been dealt with much. It's usually been at the rescue stage, and of course the longer rehab process is not being studied well enough. So that's about research. Lastly, I would say that the whole political context of humanitarian aid has been of much debate. And I know that 2005 MSF went through a major self-introspection, thinking through debate of how humanitarian aid should be progressing, should be moving along. And obviously MSF comes with a different mindset as compared to a lot of other foreign medical teams. But there are certain things which will have to fall in line, and I think we spent nearly 3 years with the WHO trying to set up standards for teams coming into other countries. And I think that was a huge exercise, because the whole handover process, who comes in, what are the training requirements, the level 1, level 2, level 3, whether you can manage outpatient, whether you can do indoors, whether you can do specialized surgery, and all these attempts to pre-register has been very, very good. Now, I know there is a lot of regulations coming into this space, which ideally earlier was not regulated. But I think most governments are looking at some kind of regulation, because I think what happened in Haiti, it was almost unacceptable. What happened in Philippines and Nepal was definitely way better. Nepal, I think, was one of the best controlled foreign medical teams exercise. And I think that's the way we need to move to the future. So the point of humanitarian aid, from being a very charitable, very top-down, very, problems flow from south to north, solutions flow from north to south, that kind of narrative obviously is changing. Clearly, this audience represents that, and it is changing, but it's still not moving fast enough to becoming a science. And that's the whole attempt of how it's going to be more of a science and less of charity, so that we have better results, as I've shown you, and we have better ethics and better consenting processes. And these are my concerns as a person who's received aid for 20 years, looked at it from the outside, and this whole use of images and imagery and shocking depictions which keep going on over and over again. And the whole humanitarian aid world is full of shocking images, and that's what tugs at the heartstrings. I have a big problem with that. I have a big problem with that because I think overuse of images and and the rescuer and rescued, I think we need to get into a more balanced equation. It shouldn't be this whitewashed tales of life-saving programs which have happened, and there's this whole needy population at the other end. I think there is a lot of ingenuity among the people you're trying to save, and I think we need to spend a little more time looking at it. I'm not saying it's black and white. I know some people do it better than the other. My point was here to remind you that it's not all black and white, and perhaps we need to be looking at and basically more engaging more sensitively to the whole problem of the recipient, and stay there much longer term. There's remarkable human agency there, and I'll end by saying that both the giver and the recipient both are blessed in the process, and we shouldn't forget that. Thank you very much.
Thank you, Dr. Nobhojit Roy. Many thanks. Before you leave the stage, probably we can take 10 minutes of questions from the audience, or comments or things that you want to add. As we said before, please be concise in your questions. Please introduce yourself and the organization that you work for. So probably we start from there.
Hi, you spoke about the 7 sins at the beginning, and you spoke about taking the aid of military forces. And if you could elaborate on that a bit more. And you also spoke about areas which are politically volatile. Say, for example, MSF working in Naxal-dominated areas in India. If you could elaborate on your take on these two issues a bit more.
Thank you. Clearly, MSF has got a different approach to politics, and I respect MSF for that. Clearly, they go where nobody else dares to go. With that, that obviously brings in problems, and I think MSF history is there. What happened in Chechnya and what happened in Rwanda, I think it's all very well known to all of you all, because you'll have lived that life. So I am not going to be able to decide what's good, what should be the political position that you all take, what MSF takes. It's remarkable to be able to go out there. I have spent too much time with the government, and I feel that I have to present the government point of view, which is that things have to be fairly aligned with what the government is trying to do. I'm not saying that is the way forward. I'm just saying that if it is aligned with the way the government is trying to approach the problem. Like, for example, Northeast, the government says it's a law and order problem. It's not conflict. 50 years they have been in conflict, but we say it's a law and order problem. Now, we can argue the merits and the demerits, but life existed on earth before you came along. Things are there for a reason. And just because we don't understand the reason why a particular person behaves that way, I don't think it's not there. So my appeal is that if that is the approach that the government is taking, it's not all bad. It's probably there for a reason. And we need to perhaps align ourselves with it. Because what I've seen is that often you go from a good NGO and become a bad NGO in the eyes of a lot of people. And that includes the local population. And I've been studying that phenomenon, which I have not covered in this talk, but why do certain NGOs, after doing 15 years of work, suddenly fall out of favor with the same populations that they have been serving? And that's a big concern, honestly. So obviously, you've gone to serve the population, and the population turns against you. And this is not being studied well enough. I have not answered your question directly, because I don't know the answer to that.
Perfect. Other questions? Peter Paul?
Hi, I'm Peter Paul from MSF. The foreign medical teams, which I think are called now the EMTs, the emergency medical teams, if I'm correct. I do have a question, because I understand the quality that countries want for teams to come in and to work. But looking at the coordination systems, looking, for example, at the UN cluster systems, are you not afraid that something like the EMTs becomes another talking shop, where a lot of people are sitting trying to get funding but not necessarily are doing the work that needs to be done at that time?
You're exactly right. Coordination, if you look at literature, it's all about not coordinating, and not coordinating. And yet the UN OCHA has come in, and a whole bunch of things have come in, and still we are not still coordinating very well. Now, it's a concern for the recipient, because you can see people stepping on each other's toes, you can see people competing with each other, and it's definitely, certainly not good. Let's look at the other, I would say, let's look at MCH, for example, maternal child health. What the government has done is, okay, there are 5 agencies looking at it, and they've handed over the state of Orissa to one agency, BMGF. Other state has been handed over to somebody else, so that you are working in different geographical spaces. The governments have succeeded in doing that in other spaces, but not in the humanitarian space, because humanitarian space, we decide where we're going to go. So I know coordination is going to be difficult, but there is an oversupply. One of my mentors from PAHO would say, if you close the doors on the humanitarian agencies, they'll come in through the window, but they will come. So I have one slide which has no in every single language in the world. No, we don't want you to come, but so this is something that we need to introspect. That's because we want to help. It's almost, it's almost helping by terrorism. You are going to come in and help whether or not so this is what I can see it from my end, from the government end. My point is to say that to you. I know I'm in a room full of the most wonderful people, good human beings, good humanitarian workers, but my point was to go beyond good intentions, and that's the whole point of this talk, not to offend you all by any means. Obviously you're here to do good, but if your good is going to take the level of amputation higher, I'm concerned, and we obviously need to get our competency levels higher up than what we have today. There are no easy answers, but I can tell you that we aggressively want to do good. Sometimes we need to probably hold back and reconsider, do a little bit of more introspection and think through things. I just have the advantage of looking at all foreign medical teams and be able to. So, but it's not going to be ethical to start saying MSF is better than ICRC and things like that. So I've tried to stay away from that.
Do we have more questions? Ashish, and then at the back. Well, Ashish.
Thank you for a very thought-provoking session. My name is Ashish, I'm from MSF, and my question pertains to your point about perhaps the need for medical organizations to stay on a little bit longer to see the after effects, the outcomes. The flip side to it is that often medical aid organizations justify the fact that they have to go to many other emergencies. So once you're done at one point, there is another pressing emergency for which you need to move on. And what would you say to that? And is there a via medium between the two situations?
So what would you think about your doctor who comes and operates on you, and he does whatever, takes away, fixes your hip, and never sees you again? What would you think of them? Is my question back to you. I mean, you would say it's completely unacceptable. What do you mean? You just come, you operate on me, and you vanish? What about physiotherapy? Who's going to take my stitches off? Who's going to correct my blood parameters? Who's going to look after me? Ashish, it's unethical. There's no question about it. Just because we're a disaster zone, just because we're in a conflict zone, which means you can just about get away with, half baked. Oh, I've got, and so my first thing of leaving is I'm a busy, important practitioner. I've got other places to go. Which is exactly my point. And I'm looking after all the people that are left behind because I've stayed behind. And why should I clean up everybody else's mess? Is the point. So I think that's where the humanitarian community has to move ahead, that we have to adhere to certain standards. I'm not saying I'm going to test your degree and I'm going to make sure, because fair enough, if I go to a conflict area in the US, they won't let me operate, but of course the US Berkeley surgeon comes to India and starts operating. Now I don't want to go on this, you don't let us do this, so we won't let you do that. Let's not get into that argument, but there has to be more accountability. And if you don't have accountability, then it's going to be the government who's going to slam something on. That's what happened in so many places, that where is the accountability? The first time that a disaster or conflict area patient sues you, and that's going to happen, I can tell you that. That's going to happen. That's going to change the face of the humanitarian world, isn't it? Suddenly you're going to just pack your bags and say, okay, these guys, they don't deserve my services. So I think we need to wake up to this, and we need to introspect a little more on it. And my job is to give you case studies. I mean, I just do workshops with case studies to say, how will you do it? Now, if you find the population getting aggressive to you, do you still continue to serve? And in MSF, you've had so many situations where you have got two parties fighting with each other, then you want to be neutral, and what is neutral is the big question. So yeah, that whole busy excuse, I am not willing to accept. Not for myself. If I was a patient, I wouldn't accept that, so you shouldn't give that to yourself.
Hi, hi. This is Hemant from the International Union Against Tuberculosis and Lung Disease. So I'm going to shift the perspective here. You're talking about international humanitarian aid working across borders. My question is within a country. You could ignore my question if it is not relevant, but within a country there are many NGOs which decide that in this particular place government is not providing health care, so I decide to go and set up a hospital. And I've seen from my experience that many of these communities are then, once the hospital is set up, is being used for 2-year projects. Okay, let's work on maternal health for 2 years. Let's work for immunization for 1 year. And there is no structural improvement within the systems. This irritates me a lot. What's your take on this?
So structural improvement, I missed that question. So is it from the NGO side or is it from the government side?
I'm looking from the community's perspective. What was the health system available to the community before? What was the health system available to the community later on? Has there been any improvement? Is it the same? You just work for 2 years on certain topic, then shift over to some other topic depending on funding. Even national NGOs get funding, right? So is the community taken into confidence? What after 2 years? Do you hand it over? So I don't see a lot of, I'm sorry if I'm not able to explain the structural improvement in a better way, but this is what I have observed. I would like to know your take on that. Thank you very much.
Can we just club a couple of questions
Sure.
in the interest of time? So you had a question here.
Hi, Dr. Roy. I'm a journalist. I work with NDTV. I was in Nepal, and you rightly said the condition. More professionally, as a journalist, I could guess it was better. So my question is, as a journalist, and pardon my ignorance if I'm wrong, that if the agencies don't move in these areas where especially in poor countries when such things happen, and we need doctors, we need health workers. So what will happen? Maybe true that you are saying they vanish, they come and they vanish. So what will happen then? Because you are saying no to them. And is it a regular phenomena? Out of 100 cases, how many cases are there? For my information, that US research says that people come and vanish without completing their work.
Thank you. I'm done. Okay. So the first question about NGOs and government, I wish I could. I can't claim that I am the government. Otherwise, I would have said more things. But the approach to NGOs of the government currently is not very healthy, I would say. So NGOs are suspect, the activities are suspect. You can see that the number of NGOs who have gone under the scanner over the last 2 years has been alarming, 60,000 NGOs. So obviously it's a changing India, to say about India. And foreign NGOs definitely are more suspect than local. So that's the situation. I'm not saying it's good or bad. NGOs basically, I think, are not to replicate the government. The government is not doing its work, so the NGO comes in, plugs in. You will never be the government. India is too big, too big. It's possible in Sierra Leone, it's possible in small other countries, and you can go and transform the healthcare system. Right? There are 12 surgeons in Sierra Leone. 45 minutes later, I have finished a national surgical survey of Sierra Leone. I sent 12 more surgeons, I've doubled its capacity in Sierra Leone. Doubled the national capacity. I mean, you can't even think of doing that in India, right? So India government is going to stay, and NGOs, just say State Bank of India is going to run India, not ICICI Bank and HDFC Bank. NGOs' job is to innovate, period. You are not there to provide services ideally. I think that's my take on NGOs. I've run 4 NGOs, and I can tell you that government is not expecting you to start doing services. You take that same PHC or you take that same Mohalla clinic and you run it in a better way, and the government learns from you, because the government is so busy just giving services, they have no time to innovate. So if NGOs are only providing service and not innovating, that is a problem. Which was my big complaint about MSF also. MSF, I think, started its research program after I have never met him, but a guy called Ronnie Zakaria started publishing in 2003. Before that, I had published my papers saying that there is no research going on, and it's not to do service. So my take is NGOs need to innovate, need to come up with new ideas, use resources better, and that is our thing. NGOs are going to keep moving around trying to do different stuff. I'm okay with that. They'll complete some programs, they will not complete some programs, they will abandon some programs, they will run out of funding. That's all a part of the game. I don't want to hold it against them. Coming back to the Nepal question, foreign aid, how important is it? That depends on the country stand on it, and you have to respect the country's stand on it. India's approach to aid comes from Gandhi. Gandhi, who said that do not use a crutch, crawl on your knees if you have to crawl on your knees, but you will be self-sufficient, it will be sarvodaya, it will be all. That's our philosophy, right? You see other countries, they're very happy to take foreign aid. So I think it's the country's stand, and you have to respect that stand. They don't want to make good progress. They don't want. I've seen countries where the Canadians are making their boats, the Chinese are making their roads, somebody's building cook stoves for them. We don't have that in India. The number of aid programs in India are very low. So definitely that's the stand they need to take. Nepal definitely has a different approach to aid, and it needed medical help, so I'm fine with that. My point is to go beyond that immediate medical help. It's dramatic, it's in your face, it's this media driven. I'm just saying that there's much more to conflict and much more to this, and serious research takes more time than media, and we need to be there for a longer period of time. So I don't think the country is going to collapse because you didn't have those foreign doctors come in, and there are enough countries who have proven that. So we need to redefine our thing, and if you're not welcome, you are not welcome, period. I think we need to respect that. That's my main thing, and we do a lot of harm by forcing ourselves in.
Perfect. We touch a couple of questions, but please ask the questions only if these topics have not been covered before. So I saw Farad, and I saw Sana and Kate, and Vishal. But please try to be really concise, to the point, and if the topics have been covered before, please do not ask them again.
Thank you. I'm tempted to say that now you start to join MSF, you will not have to calculate your 2-year salary. You did talk about two elements. I actually will have to quote them. Number one is I completely agree with you. Health is the responsibility of the nation, and eventually the nation should be the one who should be taking care of it. And you very briefly in one of the responses spoke about accountability. Yeah, and accountability is on two sides. Accountability is on the side of how NGOs should be held accountable, and at the same time how a country should be held accountable in terms of access to health care. Does everybody get equal access to health care? Maybe through your research and you have been looking at the sector for 20 years. Any observations related to accountability, but dual accountability, not on one side? If you could have some.
So we go to Sana next. You had a question, Sana? Yes. Can we get the mic there? And then Kate and Janji. And we end with that.
Hi, my name is Sana. I'm with MSF. I'm glad that you touched on innovation and the need for nonprofits to do that. It's something that MSF actually heavily invests in, and a couple of our projects in India actually, we develop models of care that we hope that the government can take on in the future. My question is about what you mentioned regarding imagery and tugging on the heartstrings of people because of the images that in some ways exploit the beneficiaries. How do you envision balancing the need for sharing a reality with the larger masses and at the same time not sugarcoating for the sake of pulling on those heartstrings?
Kate and then Chanjeev, and then we close with that. So Kate here.
Hi, Kate White, MSF. Touching on the EMTs again. The EMT mechanism relies heavily on the government that is in control to direct where the team goes to. How do we ensure that the most vulnerable populations, particularly in relation to conflict, are still accessible through that mechanism where actually they may not be in those areas that are directed or even controlled by a government?
Perfect. And the last question there, Janjeev.
Not a question really, but something about Nepal. And firstly, I endorse what Farad said, that I hope you'll work for MSF with us. I was working in Nepal after the earthquake, not for MSF, but for another NGO. And I actually appreciated your point in your keynote address that we sometimes leave a mess and we don't have a proper follow-up. The other thing also in Nepal, which I felt, was that we probably needed to do something different. The NGO I was working with, we were trekking out to places which were inaccessible, which were hit by the earthquake, to provide medical relief, which most of the NGOs were not doing. They were all concentrating around Kathmandu. The other thing I want to share with you all is what Sir also mentioned about the country issues, politics, laws. So we raised a big consignment of medicines and products to send to Nepal through the Indian Medical Association, and they were all held up at the customs, and we were supposed to pay duty. Then we checked up what would happen. They said, we'll confiscate it and send it to the government hospital. I said, that's fine with us.
Perfect. So that's the end of the questions that we take today. And yes. Thank you. Sorry, it's already been 4 questions.
Okay, so first was, I think MSF should continue to do advocacy work. That's something that they're really good at. And MSF is the watchdog for the government. And I think that role is unique to MSF. Few people have the courage to speak up and take them on, and I think that's a role which you should never give up. I'm completely an admirer of MSF ability to do that, to stand up for what is right. Just a little thing about what is right, what is wrong is again a little complex, which I cannot cover so quickly. But I can assure you I've worked with a lot of groups, and when you're working with the Meiteis in or the Nagas in Nagaland versus the Meiteis in Imphal and you start getting perspectives, and when you have like in the Northeast there are 33 ethnic groups fighting with each other, and you spend time with each one of them and you hear their perspective and you're convinced that is the perspective. So I'm just saying that everybody has a perspective, and we need to have more sociologists, anthropologists who are with us in able to understand them. Currently the trend of having psychologists with y'all in the first dispatch, ICRC has got in the first dispatch team with the trauma guys, the psychologists go, is a huge addition, because I think we have a lot to learn. All I'm saying is that we have a lot more to learn, and it's probably not as black and white as we see it to be. Next is about imagery. Imagery, I would think you should follow the same principles that is followed by the rest of the world, which is consenting. Just take consent. I think you should just take consent, and you should ask the person that I'm going to use your photograph, and that's it. That's the least amount of respect that you should have for people. I'm not saying don't use imagery. I'm just saying use the same principles that you would use in normal life. If I was photographing your wife, you would say, why are you photographing my wife? And I know I would ideally want to take your permission for that. So I don't know, that's an oversimplistic answer, but I think let's just try and let's not keep treating it as a different situation. Let's have the same framework of ethics that you have. Now this is already there now on paper. The consenting process, the ethics, and all people have written about it, and it's already being done by the WHO. So we should be able to do that. Kate White said controlled areas and non-controlled areas. Yeah, big problem. Okay, no easy answers to that. Again, people don't want foreign teams to go to certain areas because for a reason. It could be that the risk is too high. It could be that we don't want to see what is going on there. There are 100 reasons. All I'm saying is that somewhere you have to decide that you're going to go against the government or go with the government, and that's a thing that MSF will need to decide for themselves, because you've tried doing both things and have enough MSF examples to show that you've tried to do this and you've got yourself into trouble, and you've tried that, you've got yourself into trouble. So it's a call. It's not an easy solution, but I would say that if the government does not want you to go somewhere, I would say it's not a good idea. That's all I can say. But it's your call, honestly. It's not an easy answer to give. Yeah, about the consignment. There have been good consignments and there have been bad consignments. And you know, all the disasters and everything else, you start receiving blankets in warm Bangladesh and neckties in Rajasthan, and you know, you've seen all kinds of consignments. I still wear a lot of those neckties that I received as consignments. Now, again, there is a whole UN and WHO document on consignments, how it should be, what needs to be sent, how it needs to be sent, what should be the clearing agencies that should be involved in. So it's all been systematized, because we were getting too much of unintended gifts, and you will get to see that in a lot of these places there's always this big warehouse, and it's normally written junk for Jesus. You see that? So it's most of us recipients have a junk for Jesus warehouse where all the junk that you've received has come in, and there are heart-lung machines, there are ventilators, there are all kinds of stuff which you never asked for which have come in. So I think that whole consignment process goes both ways. If the government has not asked for a consignment and you've sent a consignment, then you're getting upset, it's sitting in the customs, and then you say that, well, I have been a recipient for that. In one of the earthquakes, I was told 4 crores worth of drugs have come in. And I actually went to the ship to examine the consignment. It was all in a foreign language, a language which I will not reveal, but it was, all the drugs were stamped in a foreign language. How am I going to understand what's going on in that? And I was told that it's 4 crores worth of consignment. Obviously I didn't release it. we couldn't dump into the sea because the fish will die if they have all those drugs. So what do you have to do? We actually had to spend more time burying all that drugs than receiving the consignment, and this is happening in the middle of it. So there are stories on both sides. All I'm saying is that there are stories on both sides. You come up with a story, I'll tell you a recipient story which is going to be countering that. So we are all in this attempt to do good, but obviously we need to align ourselves better.
Perfect. Dr. Nobhojit Roy, thank you so much for a very interesting perspective on humanitarian medicine. Thank you. So we had about 350 plus people who were watching the entire session on live streaming from a number of different countries, from Philippines, from Ukraine, from Peru, from a lot of these countries. The reason I say that is because we also need to respect their time. Many of them come from different time zones. They're following the agenda that we published, which means we take a break now, but we do come back at 1:30. So it decreases our time for lunch a bit, but I'd still like to stick to the time. So 1:30, we get back to the room and we have our lunch here. So have a great break.